Neoplasm, serum Dr. Sumit Gujral. These are some of the reminders. I would like to request that please do not send any request for annotation to the presenters as it disturbs the speaker during their presentations. Some of the disclaimers. Some more disclaimers. And kindly note down our upcoming talks and upcoming slide seminar is on 9th of March, again on plasma cells neoplasms, a case-based approach. The presenters are going to be Dr. Prashant Tembhare and Dr. Neeraj Arora. And on 14th of March, we have another talk in MRD in acute leukemia, again by Dr. Prashant Tembhare. So with this, I would like to request Dr. Pamela ma'am, welcome her and to please request her to share her screen.
Thank you. Thank you, Preeti. Yeah, so we will start with understanding multiple myeloma and laboratory investigations. Basically, to understand what multiple myeloma is, we need to know what is an immunoglobulin. When foreign substances like antigens enter the body, the beta cells develop into plasma cells that produce immunoglobulins, in other words, antibodies, to help fight infection and diseases. So this is a normal immunoglobulin structure. It is Y-shaped, which you will be knowing, okay, and it has a heavy chain and a light chain, which is attached by disulfide bonds. So as we know, we have 5 different types of heavy chain, that is the G, A, M, D, and E, and 2 different types of light chain, that is the kappa and lambda. So the serum immunoglobulin pool is produced by multiple plasmocytes, which is the final differentiation step of the B lymphocytes. And an adult organism may have around 10 raised to 20 different immunoglobulins, leading to a polyclonality. There is abnormal synthesis of immunoglobulins, which could be due to various etiologies. And you can have 3 different types of production of clones. One of it is stimulation of multiple clones, leading to polyclonal hypergammaglobulinemia. Second is selective stimulation of few clones, that is known as oligoclonality, which could be biclonal or triclonal, 2 or 3 clones. Then you can also have excessive production from one clone, which is known as monoclonality. So coming to this slide, you can see the normal, which I've already told you, and in a myeloma cell, in a condition, due to genetic damage, you can have a damaged B lymphocyte, which gives you a malignant plasma cell, which is a myeloma cell, and leading to finally abnormal immunoglobulins. So, multiple myeloma is said to be a progressive hematologic blood disease. It is a cancer, a malignant proliferation of a particular type of plasma cell derived from a single clone, which is programmed to produce a particular type of immunoglobulin in very high numbers. So this multiple myeloma cell results in finally overproduction of monoclonal immunoglobulins. Now keep in mind, I have mentioned that one particular type of plasma cell decides to proliferate. Okay, so that leads to a particular type of monoclonal immunoglobulin, which could be either IgG, A, M, D, E, and or a Bence-Jones protein, which is basically a free monoclonal kappa or lambda light chains. And this can be identified on serum and or on urine protein electrophoresis as a narrow, dense band. Representation of a normal cell, plasma cell, giving you different types of antibodies. These are all different types, GAM, which is present in a normal person. A myeloma cell decides to produce only one type of antibody, as you can see in this picture, and that too in large numbers. There are different types of multiple myeloma. Two are most common. That is the intact IG myeloma, where you have the whole immunoglobulin. You can also have the light chain myeloma, either with light chain production of only light chains in large numbers. So, the multiple myeloma cells collect in the bone marrow, where they cause permanent damage to healthy tissue. In most cases, the myeloma cells is spread into the cavities of large bones of the body, forming multiple small lesions. And this is why the disease is known as multiple myeloma. So now that we understand what is an immunoglobulin and what is an abnormal immunoglobulin leading to a myeloma disease, we come to the lab investigations. So usually samples are sent to pathology or to the biochem department. Among the biochem parameters, the main ones are quantitative immunoglobulins, serum protein electrophoresis, serum immunofixation, urine protein 24 hours, urine protein electrophoresis, kappa and lambda free light chains, which is done in serum. So now we come to the technique, serum protein electrophoresis. I will tell you the principle of serum protein electrophoresis, which is done on capillary electrophoresis system. So basically, protein electrophoresis is a technique routinely used in clinical laboratories for screening samples for protein abnormalities, especially multiple myeloma. Capillary electrophoresis has been developed to provide a complete automation with fast separation and a good resolution. The charged molecules are separated by the electrophoretic mobility in an alkaline buffer with a specific pH at around 8.8 to 9 in silica bone fine capillaries. So this is what it would look like. The basics of an electrophoresis, any electrophoretic system is made up of three basic compounds. You have the support media, earlier electrophoresis, and in some places also as of now, electrophoresis is done on an agarose gel. So basically you have the support media, you have the electrophoresis chamber containing the buffer, and you have the power supply. So in capillary electrophoresis, the principle is like this. This is the capillary. Okay, this is on this side, you have the injection of the serum or the proteins in the serum. On the capillary wall, there is a negative charge, and the positive charge comes from the buffer solution. Okay, so you have the negative on the capillary wall, you have the positive coming from the buffer solution. So now there are two types of forces. One is the electroosmotic force and the other is the electric field force. So these two forces, between these two forces, the electroosmotic force is a stronger force than the electrical field. So this force takes the proteins from this anodic end to the cathodic end where it is detected, because this force is stronger than the electric field force, which is trying to push the proteins this side. So this is how the capillary is in a silica bone inside that, and you have the migration from the serum proteins into, comes on this side. A deuterium lamp is there where you have a detector which detects the proteins in the form of bands and also gives you an electrosporogram. So now this picture will explain to you how a normal sample is seen on an electrophoresis. Normal plasmacytes, these are all the normal plasmacytes, produces normal immunoglobulins, each which is programmed for a specific type of immunoglobulin. So in a normal person, a normal production of various immunoglobulins gives you a pattern like this. This is an electrophoregram. Okay, and this is the electrophoretic pattern, which I will show you in detail in my next slide. So what I'm trying to show you in this is the normal production of immunoglobulins is shown as a very small hump in the gamma region, which is explained here. So you have this is the pattern, the bands. You have the albumin, first band, then you have the alpha 1, alpha 2, the beta 1, the beta 2, and the gamma region. In this normal pattern, there is no increase or deformation or any additional peak in the gamma, the beta 1 or the beta 2 and the alpha 2 zones. Each of these, as the alpha 1 has got different proteins, the alpha 2 has got some proteins, the beta 1 has got some proteins, the beta 2, and then you have the gamma made up of the immunoglobulins. So on a serum immunofixation, the normal pattern on electrophoresis will give you a pattern like this. It will give you something like this. So what is immunofixation? We have seen what the principle of electrophoresis is. Immunofixation includes two steps. The first is electrophoresis. That is that molecules move from the anode to the cathode to give you the pattern. The second is, so you have the electrophoretic step that causes them to move. In the second step, there is an antibody added to each of these lanes, specific antibody to G, A, M, K, and L. And then there is incubation. So wherever there is immunoglobulins, it forms some type of a broad band or it could be a narrow band depending on the disease or whether it's a normal. So this is a normal IFE seen in a normal person. In a monoclonal or a myeloma, multiple myeloma case, you have a malignant transformation of plasmacytes. So this particular plasma cell, which is of malignant disorder, gives you a number of immunoglobulins of AK, for example, which is called the monoclonal immunoglobulin, a disease form. And this one that gives you large number of monoclonal immunoglobulins is seen on the band, on the pattern as a narrow, dense band, which I show you here. And on the corresponding on the electrophoregram, it shows you as a tall peak depending on the dense band that is present. So these are some of the patterns. You have a monoclonal component in the gamma. You can have it on the beta. Basically, it can be anywhere between the alpha 2 and the end of gamma. So this is a pattern, a gamma M band, which can be quantified based on the total protein. It gives you the percentage of M band present with respect to total protein for the particular patient. This pattern is a representation of an IgG kappa. So you have, can you see the band here, which is narrow and dense, and narrow dense G and a kappa, as compared to what you have seen on a normal IFE, which does not have this kind of sketched out, very sharp, narrow dense band. This is the beta, This is the electrophoretic pattern. This is the electrophorogram. This is the IFE. This is A and K. Some more patterns. You have the ML. Here you have the A and L, which is faint. You have the A and L, sorry, the G and L here, which is prominent. And on this side, you have the faint IgG kappa. Some more the
Sorry
MA.
for interruption. There's just a request if you can use the laser pointer.
I don't have the laser pointer. I checked it earlier.
Okay.
Okay. So those were some of the patterns that we have seen for multiple myeloma on different types. We also do get hypergammaglobulinemia. Now, the difference between hypergammaglobulinemia is you have a very broad diffused band in the gamma region. Can you see my arrow?
Yes, ma'am.
Ma'am, we can see the arrows.
Okay, fine. So you have a very broad as compared to the dense band of a myeloma type. So this on an electrophorogram, you have the base which is very broad here as compared to the myeloma pattern, the peak on the electrophorogram which is narrow and dense for the multiple myeloma. So this is an hypergammaglobulinemia, and on an IFE, you can see this is broad and diffuse, which is the polyclonal increase of IgG. Opposite to this, you can also have a patient can have, this is another type. This is hypogammaglobulinemia. There is no M band here, but the patient has got a very less immunoglobulins. A third type of test that is done is the urine Benz-Jones protein on an agarose gel. This is a gel which has 15 different patient samples. A normal person will not have any pattern, any bands on showing on the strip. There are some patterns which show heavy protein urea. So these are all generalized protein urea. But these are the ones, number 4 and number 5. I've got a narrow, dense band. That is very, very typical of a myeloma case. So this is the BJP, which we say as BJP positive, which is a light chain. Here you can see one faint and you can see a strong BJP positive. So this is how it shows on a gel which is done for urine Benz-Jones protein. So there's about 15 to 20% of patients with myeloma produce incomplete immunoglobulins, which is light chain plus partly heavy chain. And these contain only light chain portion of the immunoglobulin, which is primarily seen in the urine. Some more patterns of biclonal. Biclonal gammopathy will have two bands. As seen in this pattern, there are two narrow dense bands giving you two peaks, sharp peaks. On an IFE, it is seen as IgG kappa and IgA kappa. Another pattern which shows IgM kappa, IgM lambda. So there are various combinations. Here you have IgA kappa, and you have IgG lambda. So this is actually the reference pattern. The first is a reference pattern. If the reference pattern on an IFE has a band, it has to have a corresponding band in the heavy chain lane and the light chain. So here you have the M kappa and you have the A lambda. This is a gel which is done. This is an agarose gel. You can see some normal patterns. There are about 30 patient patterns, samples on this gel representing 30 different patients. Some of the bands are like this. You have it in the gamma region or below the beta region, some representations. Another biclonal, which we've got recently. Okay, this is the IgA-K. Both belong to the IgA-K. So this could be a distorted IgA-K because it comes into another clone and forms another band. Thank you. I now hand over to Uday, Dr. Uday, who will take you over to the multiple myeloma diseases and disease and various cases.
There was only one question if we can take over here on electrophoregram. What is ELP?
ELP is electrophoresis.
Thank you, ma'am.
Short form.
We have another question, ma'am.
Yes.
Biclonal cases, how we differentiate from reactive?
From reactive.
Yes, ma'am.
That question, I think Dr. Uday will be able to answer.
Yes, ma'am. We can take that later.
Later, okay, yeah.
Okay. So are my slides visible?
Yes, sir.
Yeah. So yeah, I think Pamela madam has already covered the initial pathophysiology in myeloma, so it makes my job simpler. So as you already know that multiple myeloma is a neoplasm arising from a plasma cell, and plasma cell is the final product of the B cell maturation, and the function of normal plasma cells is production of immunoglobulins and which contributes to the humoral immunity. So as madam just alluded to, normal plasma cells are polyclonal and they produce polyclonal immunoglobulins. So what happens in multiple myeloma is that there is a abnormal plasma cell proliferation, and that produces an abnormal immunoglobulin, and this is what is called as the monoclonal protein or the M protein. And this protein being abnormal, it does not help in, it has no role in the immunity, and patients continue to be susceptible to infections despite having very high immunoglobulin levels. So if they have monoclonal accumulation, these are not functional immunoglobulins, and hence in fact these proteins cause end organ damage in the blood, kidney as well as bones, and this is what patients manifest with when they present with symptomatic myeloma. So multiple myeloma forms about 1% of all cancers. 10 to 15% of all hematologic malignancies are multiple myeloma. And the median age is around 66 years. About 10% of our patients are less than 50, and men are more affected with this disease. So just to recapitulate that all multiple myelomas are a result of progression from a precursor lesion called as monoclonal gammopathy of undetermined significance. So what happens pathophysiologically is that there are primary genetic events like immunoglobulin heavy chain translocations and hyperdiploidy, which lead to initiation of this process of monoclonal gammopathy of undetermined significance. So patients develop a small M protein detectable in the blood and they are otherwise asymptomatic. What happens predictably over time is that these patients accumulate secondary genetic events in form of copy number abnormalities, DNA hypomethylation and acquired mutations, and this leads to formation of clonal malignant plasma cells. And the disease progresses from monoclonal gammopathy of undetermined significance to a smoldering multiple myeloma and then a symptomatic multiple myeloma. This can further progress to a plasma cell leukemia. And what is peculiar is all patients with multiple myeloma develop from this precursor lesion called monoclonal gammopathy of undetermined significance, and this can happen over many years. So as we saw, what happens is patients with monoclonal gammopathy of undetermined significance, they are asymptomatic, and over a period of time they develop active myeloma wherein the M protein increases. Then some form of, because they are symptomatic, they present to the healthcare system and they are picked up with active myeloma. Therapy is initiated. Some form of reduction in M protein happens with treatment, and they again they achieve a plateau or a remission status. However, currently with the current understanding, myeloma is not a curable disease. So at some point of time, the disease progresses and these patients have a relapse. Again, with some form of therapy, they might achieve a plateau. But as you can see, the remissions are shallower and shallower with each relapse, and ultimately patients progress and succumb to the illness. So now that we have seen the natural history, we would come to the diagnostic criteria for these disorders. So as we saw, this monoclonal gammopathy of undetermined significance, I had shared this article also with all of you. Is defined as monoclonal protein, M protein being in the blood being less than 3 gram per deciliter, clonal plasma cells in the marrow being less than 10%, and absence of a whole lot of features. So let's go through these one by one. So there is an acronym CRAP for this, which is calcium elevation or hypercalcemia above 11 milligram per deciliter or 1 milligram per deciliter higher than the upper limit of normal. And we generally use a correction for the albumin. So the calcium levels have to be corrected. If there is hypoalbuminemia, the corrected calcium is much higher. R stands for renal insufficiency, wherein if there is creatinine clearance of less than 40 or serum creatinine of more than 2 milligram per deciliter. A is anemia, hemoglobin being less than 10 gram per deciliter or a 2 gram fall from the normal. B denoting bone disease with one or more lytic lesions on the skeletal radiography, CT or a PET CT. So that's the CRAB features, which essentially indicate that the disease, the level of plasma cell accumulation is causing symptoms. So either there is hypercalcemia, or there is renal insufficiency, or there is anemia, or they have lytic lesions. Now what happened is in the 2014 update, 3 additional features were considered as myeloma defining. So as we saw previously, it was only CRAB features, which essentially most of these patients would be symptomatic. If they have hypercalcemia, they will have altered sensorium, some mental abnormalities would be there, renal insufficiency would be detected on routine biochemistry, anemia or bone lesions. These are all evident form of disease. The revised criteria included myeloma defining events as if there is 60% clonal bone marrow plasma cytosis, that itself is a myeloma defining event. So you don't need any further derangement in calcium or hemoglobin or creatinine or bony lesions to call it myeloma. So that's 60% clonal plasma cells or a serum involved free light chain ratio of more than or equal to 100, or MRIs of the skeleton showing more than one focal lesion of more than 5 mm size. So these criteria were added to the regular the CRAB features. So in monoclonal gammopathy of undetermined significance, the M protein is less than 3 gram per deciliter, clonal plasma cells are less than 10%, and none of these features are present. Vis-a-vis this, in smoldering myeloma, you have M protein which is more than 3 gram per deciliter as compared to MGUS, whereas it is less than 3, or in the urine the protein is monoclonal protein is more than 500 milligram over 24 hours, and the clonal plasma cells in the marrow is in the range of 10% to 60%, because if it goes above 60%, as per the revised criteria, it will directly classify as a myeloma. So smoldering myeloma, again, none of these features are present. Neither the CRAB features nor these 3 myeloma defining events are present. Now, vis-a-vis this, multiple myeloma is defined as an underlying plasma cell proliferative disorder and one or more of any of these criteria being present. The criteria for calling a multiple myeloma, any of these criteria with bone marrow showing more than 10% plasma cells or a biopsy proven plasmacytoma. That's the current definition of a multiple myeloma. So when we see these patients in the clinic, some of these patients would present with fatigue, bone pain, anemia or kidney failure. Some of them may have symptoms related to hypercalcemia. Some of these peculiar symptoms would include increased total serum protein, sometimes causes hyperviscosity symptoms, wherein they have slowness and mentation, and behavioral changes can happen when the M protein, the monoclonal protein is very high in concentration. These symptoms can occur. Uh, Patients can have lytic lesions on bone imaging, or very commonly we see compression fractures in the vertebrae. So the diagnostic criteria that the diagnostic testing Dr. Pamela has already alluded to. So we do the same panel of investigations which was discussed, including a complete blood count, metabolic panel, calcium level, serum protein electrophoresis with immunofixation, free light chain ratio, 24-hour urine protein, and urine Benz-Jones protein, beta 2 microglobulin, and LDH for risk stratification. And we do some form of a skeletal survey, or if resources permit, then a whole body low dose CT. And based on these, then we decide whether, if there is a detection of a monoclonal gammopathy, then we proceed with doing a bone marrow aspiration biopsy and fish analysis on after plasma cell enrichment. Fish analysis is done for further stratification. So we went through the diagnostic criteria. So briefly, through the prognostic stratification also. So the revised international staging system is based on serum albumin, beta 2 microglobulin, LDH, and these abnormalities detected on karyotyping or fish. So the revised international staging system, if you classify these patients as stage 1, essentially the serum albumin is more than or equal to 3.5 gram per deciliter, and the beta 2 microglobulin is less than 3.5 milligram per liter. They have a normal LDH, and they do not have any of these three high risk cytogenic abnormalities. Whereas stage 3 is when beta 2 microglobulin is more than 5.5 milligram per deciliter, and they have high LDH, or any of these three high risk karyotypic abnormalities are there. And as you can see, the overall survival is different for all these categories. Essentially, stage 3 having the worst prognosis. So we use this revised international staging system routinely in the clinic. So this is the last slide of the treatment slide set. After we have diagnosed these patients and we have done the risk stratification, we determine whether these patients are transplant eligible or they are transplant ineligible, essentially based on their performance status and age. And in patients who are transplant eligible, the current treatment algorithm includes giving induction chemotherapy, which is generally a combination of three drugs, chemotherapeutic drugs that we use. And with this induction, as you can see, the tumor burden, the goal of the induction is to bring down the tumor burden. So after we finish the induction and we have gotten some control of the disease, we go ahead and do consolidation with the autologous transplant. So autologous transplant essentially further pushes the disease burden down. And with this, post the consolidation with autologous transplant, we continue some form of maintenance therapy with the hope that we continue to maintain the disease at very low levels. So that's the current understanding of the myeloma treatment. At some point of time, the disease comes back, and then we give salvage therapies and we are managing a relapse at that time point. In patients who are transplant ineligible, So we cannot do the autologous transplant in them. So we give them induction therapy, and then some form of continuous therapy goes on with the hope to control the disease for as much time is possible. And ultimately, in these patients also, some of them, the disease comes back. So is any questions so far from the students?
Yes, sir. There is a question related here. Is this spectrum of MGUS, smoldering myeloma, multiple myeloma being followed in 100% of cases, or multiple myeloma can arise de novo also in cases without this spectrum?
No, in my understanding, this is quite consistent, and it's 100% that every myeloma is preceded by MGUS over some period of time, and in the clinic we see patients presenting directly with myeloma, but the current pathophysiologic understanding is that all of these patients at some point of time had an MGUS few years back, which was probably not detected.
Okay.
I hope
Students,
that
any of the students
answers
have
the
any
question.
questions here?
There was one question on biclonal cases, how we differentiate from reactive.
Yeah, so basically, what we do is uh, we routinely we do collect samples for flow cytometry also. Uh, in the immunohistochemistry on the tryphin as well, one can determine if there is light chain restriction, then you can show clonality. So the reactive plasmacytosis on the marrow, one can differentiate by using light chain restriction. That's a standard practical way of differentiating between reactive causes. So I agree that sometimes when we have IgA myeloma, which falls in the beta region, sometimes it's difficult to detect, and you know the I suppose the question was between biclonal and reactive, right? So
Yes,
the
sir.
So
I
yeah,
think
I
serum protein
agree with,
electrophoresis and immunofixation would clearly tell us whether it is biclonal vis-a-vis reactive causes. So
yeah.
it's
Yeah, I agree with Dr. Uday. I think our experience has been if the biclonal is coming from two different clones of plasma cells, they would produce a sharp band. It wouldn't be ambiguous. And like Dr. Uday mentioned, we could proceed with an immunofixation and clearly define which heavy chain and light chain they belong to. But very often, if it's reactive in nature, we have seen that the bands are not clear or dominant. They would be very small, and they would be so inconspicuous that you can't really put your finger on it and say this is a clonal protein. So we have seen two bands, minor bands, or three minor bands. We call them oligoclonal, like Dr. Pamela had mentioned in one of her slides. And those are generally reactive in nature. Uh, Practically, we have not come across challenges to differentiate biclonal bands from reactive oleoclonal bands.
any other questions from students?
Yes, sir. We have two more questions. One is how to
Or
establish the clonality of plasma cells to fulfill the criteria of MGUS, SMM, or MM. Is flow cytometry is a must?
No, we do flow cytometry only. For sometimes what happens is if you detect an M band, uh, it's it's not necessarily a plasma cell dyscrasia. You can also have an M band in B cell, other low grade lymphomas can present with M band. So for that reason, we generally routinely collect flow cytometry, but I agree with you, it's not for a diagnosis of myeloma. So generally based on immunofixation and the crab features that we described, and the refined biopsy or a biopsy from the plasma cytoma. So that's a must. So we do a biopsy from the plasma cytoma if there's a plasma cytoma, or do a trifine, and showing clonal plasma cells on that is what we routinely do. But the flow cytometry is generally taken, samples are taken for flow cytometry essentially not to miss, sometimes if you surprisingly, diagnose a low-grade lymphoma like Waldenstrom's, you should not miss that. That's why we collect a flow cytometry at diagnosis.
So another question is how to logically that MGUS is going on. What sort of investigation can pick it up?
Yeah, so routine, if there is A by G reversal which is detected on routine liver function tests, one can do, or just screening also with serum protein amyloidosis. It's essentially asymptomatic. It's unless you do the electrophoresis, you would not pick it up.
Yeah, so what we have done is we've been doing electrophoresis as part of liver function test for many years now. And we have been able to pick up MGUS in unsuspecting individuals who have just come in for executive health checks. And we have seen a good percentage of MGUS asymptomatic, but then progressing to myeloma a couple of years later. We've also picked up vague aches and pains in executive health check. And when we have done electrophoresis as part of EHP, we have been able to pick up the M protein and diagnosed as multiple myeloma at that point in time. So it's a good question how to detect pathologically that MGUS. You can't do it because they're asymptomatic. It's only a screening tool, like Dr. Uday mentioned, that we can screen them during their health checks.
So we have more questions coming up. One is, how is plasma cell leukemia different from multiple myeloma pathophysiology as well as genetics?
It's in what I understand is that it's when the myeloma acquires more genetic sort of lesions, then it becomes a plasma cell. In plasma cell leukemia will have a higher burden of genetic lesions than myeloma, and it's a clinically very aggressive disease, plasma cell leukemia. So yeah, it's a very aggressive form of subtype of leukemia, and it's because of progression from myeloma to the leukemic phase.
Is there any specific criteria to prove clonality with plasma cell morphology?
I would request Dr. Sujay or morphologically.
Meaning, is there any specific criteria to prove clonality with plasma cell morphology? When you look at the criteria for diagnosis, I don't see that coming up as a requirement at all. So I would think if you have the investigations that Dr. Pamela and Dr. Uday have mentioned, that would give us enough indication as to know that there is plasma cell neoplastic process. And with a biopsy, I think we have the answer along with the immunohistochemistry to look for light chain restriction.
There is one more question. What is the total duration of chemotherapy given for these patients, and what is the standard guidelines to perform bone marrow to know the disease status? I think
So,
they want to know when all to perform the marrow to know the disease status.
So
Duration of.
at diagnosis, for sure, we do a bone marrow examination. The second marrow is done generally after induction therapy before we proceed with the autologous transplant. Post that, it's even whether to perform a marrow before autologous is not really, it's more to document responses, whether if somebody, the monoclonal protein, suppose if there is say 50% reduction. So whenever we start therapy, we define a measurable disease. So what we are going to measure in myeloma is identified. So for example, if the M protein is more than 1 gram %, so that is defined as the measurable disease, and we would follow the M band for this patient. In some individuals wherein it's a light chain myeloma or the M band is less than 1 gram, we would follow the free light chain ratio. So before the autologous, if the M band has completely disappeared, so in order to document complete remission, we would do a marrow. Beyond that, unless we are suspecting a relapse, we don't perform a routine marrow. So at diagnosis and in certain situations before an autologous is what we do.
Dr. Uday, for MGUS who's asymptomatic, would you do a bone marrow?
So, the definition of MGUS would need a marrow. So, for defining MGUS itself, you would have done a marrow. So, I think if they become symptomatic, of course, if they have, with a suspicion of progression, one would do a marrow.
What about MRD, minimal residual disease by flow cytometry? That's part of the guidelines now to do MRD in these patients before.
So we are doing that as a part of, yes, we are accumulating data on that. But I think even now it's not it's not used. It's more of prognostic
Decision making.
rather than useful for taking treatment decisions, is what I understand. Because it may be prognostic, but whether you would use MRD for making a therapeutic decision in myeloma is something which I am yet to see and understand, because I think currently it's more of prognostic rather than
Yes, sir.
being useful for taking a therapeutic decision.
Right. So these were all the questions I think we have here. From our students, I would like to request if any of you have any questions here,
Shall we proceed with the cases then?
and proceed.
Okay. Yeah. So the first case, Dr. Ishita, would you
Yes,
like
sir.
to read out the case? Yeah.
Yes, sir. Case 1, 55 years old from Assam, bank manager. See, with the complaints of severe low backache, compression fracture of L1 and L3 vertebrae. Investigations done on Jan 2020 shows hemoglobin is reduced and there is increase in the total protein and
Yes,
corrected
that's right.
calcium is mildly increased.
Yeah, you are right. So the total protein is 11 and albumin is only 3.5.
3
There is
yes.
A by G reversal. So what additional tests would you order?
Uh, so we can look for electrophoresis
Okay,
and
so this
bone
is
marrow studies. Yes.
what the electrophoresis showed. Can you identify the abnormality here?
Yes, sir. There is a peak in the gamma region, M spike.
Yeah, that's right. That's correct. So Dr. Heta,
Yes, sir.
so
So there is a band in IgG region with the light chain
and
kappa,
what is this
which shows
test?
an
This is a result of which test?
immunofixation.
This is immunofixation, right?
Immunofixation.
Okay. And there is a IgG kappa band. Yeah, that's right.
IgG kappa.
Okay. So Dr. Manoj,
Yes, sir.
would you like to interpret this slide?
So
It is
there's
shown in the red arrow.
a red arrow. There is a
This
spike.
is a urine. Dr. Pamela, if you can
Yes.
also pitch in, ma'am.
Yes, maybe I can help him out, Dr.
Yeah.
Manoj. So this is the gel for urine samples. Okay. So what do you think you will see? What is abnormal protein, myeloma protein in the urine? What is it
Ben
called?
Ben's-Jones
Jones,
protein.
right. So this is how would you interpret this? It is a BJP positive.
Positive.
Okay, so that's different from the others. These are all protein urea, generalized protein urea. Fine. Yes, Uday, next.
Next one is Yeah, so just summarizing the results. So this patient had a M band of 4.5 grams. IgG was, this is done by routine nephelometry. So IgG was 4,400. 24-hour urine protein was 552 milligram percent. Urine Benzone's protein was positive. Immunofixation showed IgG kappa, and the aspiration showed 53% plasma cells. And we did a FISH, and we found that this was done after plasma cell sorting, and 94% cells had deletion 17p. So anybody wants to take that question? Where in the risk stratification would this patient fall?
So high risk.
High risk.
Yeah, so the deletion 17p was high risk. So we treated this patient with 4 cycles of cyclophosphamide, bortezomib, dexamethasone chemotherapy, and then again, 4 cycles of bortezomib, lenalidomide, dexamethasone, because the M band, the response was not optimal. So what test should be done to assess the response? So Dr. Lakshmi Lekia.
Okay. So they can follow up the patient with these serum electrophoresis, beta microglobulin levels.
So, right. So we followed up the patient with serum protein electrophoresis, because if the M band is more than one can use that for following up, to see the treatment response. So we did the M band again. So this was after 4 cycles of Cybord D chemotherapy, and the graph below is after 4 more cycles of VLD. So as you can see, there is progressive reduction in the M band with treatment. So post that, as we saw, the M band initially was 4.5 grams. It reduced to 2.38 after the first set of chemotherapy. Then after the next set, it reduced further to 1 gram. So post that, we did the first autologous transplant on him. So generally in the high risk patients, we do tandem autologous transplant. So we did the first autologous transplant, and as you can see, this was the M protein was 1 gram before the first, and after the first autologous transplant and just before the second one, we repeated the M band and it was 0.57. So we did 2 transplants back to back to ensure that the disease is well controlled here. So post-transplant, what tests should be performed and what should be the maintenance strategy post-transplant? So as you can see, we did an assessment again at around, generally we do an assessment at around 3 months post-transplant. So we did that assessment, and the serum protein electrophoresis showed an M band of 0.54 and the free light chain ratio was 3.5. Immunofixation continued to show IgG kappa. So routinely we start these patients on, high risk patients are started on dual maintenance therapy. So we started lenalidomide and bortezomib. Next thing what happened is, when on routine follow-up at 6 months, this patient came and we did free light chain ratio, which was again 2.35, kappa of 112, lambda of 47, serum protein electrophoresis, M band increased from 0.54 to 0.8. So we were a bit concerned here that what needs to be done further. Anybody would like to take this question? What should be done next?
Go for the immunofixation.
Dr. Zara?
Sir, on the next treatment plan, we can go for the immunofixation.
Yeah, so the immunofixation here showed IgG kappa, the same protein. So, below 1 gram, the
It's not much significant.
light chain. Small changes in M band, one should not really react generally. There is the Dr. Pamela, would you like to comment on this, whether the sensitivity of the assay below 1 gram percent?
Yes, it is. Capillary electrophoresis is quite sensitive. But
Okay.
when you have 1 gram, 0.3, it picks up 0.1 as well.
Okay.
There's a high sensitivity. But
Okay.
then anything below 2.5 to below 3, I think, is the BMGUS, right?
Yes.
Yeah.
So we do see small M bands, this
Faint bands, yes.
post transplant, and generally these are just followed up. But because we were worried, we did a marrow on this patient. So at 6 months, because the M band, from 0.54 increased to 0.8, we did a marrow with MRD, and I don't really understand much of this, but my pathology colleagues have told me that this was MRD negative. So apparently, this is the abnormal plasma cells should fall somewhere in this
Lower left.
this square. Dr. Sujay or anybody else would like to comment on this? I would.
I can help you with this, sir. I'm Dr.
Yeah.
Shweta here, sir. So
Yeah.
basically, using CD38-138, the plasma cells are gated. And when we look at these plasma cells, they fall completely, like they are distributed between kappa and lambda. So, and if we look at the other abnormalities using CD56 is there, CD56 is negative, and CD27 is normal plasma cell marker. So, in CD27, they are positive for 27, they are positive for 19. So, like the zone where 27 negative, 19 negative, abnormal plasma cell usually fall there. And abnormal plasma cell may also be CD56 positive. And here we can see that these are showing a good kappa lambda distribution. So that means these are actually polyclonal.
Yeah, so thank you so much for that. So I think these were essentially the MRD was negative on this, and so we're happy with this result, and we kept him under follow up. So the M band rise was transient post transplant, and this was his recent electrophoresis pattern, and that 0.54 increased to 0.8, and then after that, without change of therapy, the M band went off. So without change in any therapy, the current M band disappeared and is clinically well and is in remission. So that's the first case. Any questions related to this, or
Yes,
should
sir.
we move on to the second
Interestingly,
one?
yeah, we have a similar question. Sometimes in a treated myeloma patients, there's paradoxical increase in the uninvolved light chains. So any
Yeah.
particular reasons why it happens?
I'm not aware. I'm not sure. Dr. Sujay, any
No,
comments on that?
it could be a reactive process, but really I don't think I have an answer for that.
Okay,
Sorry.
so we can move on to the next
Yeah.
case.
Okay, so the second case, Dr. Yashika Sharma,
Yes,
would
sir.
you like to
Yes, sir.
read out the case?
Yes, sir. 28-year-old from West Bengal complained of fatigue, weight loss, and difficulty in walking. The PET scan showed single expansile sclerotic lesion in the left ileum, and the biopsy showed plasmacytoma. He also had polyneuropathy and hepatosplenomegaly. The investigations are given.
Yeah. So, yeah. So, what additional tests should be performed? What is the abnormality that is noted on this?
Cohen syndrome.
There is little bit of the total protein albumin ratio here also. The albumin globulin ratio is a bit altered. So, what additional tests should be done? So we did a serum protein electrophoresis.
Serum electrophoresis.
So what does this show?
There is a
M spike in the
in
gamma region.
Anyone wants to take that question? What is it showing?
Sir, M spike.
Abnormal protein, right?
The gamma
Is the monoclonal protein.
Monoclonal protein.
Anybody? interpretation of this graph? What is this graph showing?
Sir, IgG and the lambda. Their
Yeah, so there is a IgG lambda on the immunofixation. So to summarize, this patient had an M band of 0.77. Urine Benzene protein was negative. Immunofixation was IgG lambda. The bone marrow aspiration, there was only 2% plasma cells. And we did expansile lytic lesion was biopsied, and that showed a plasmacytoma. The free light chain ratio was 2.2, kappa of 160, lambda of 71. So essentially this patient had Poem syndrome. So he fulfilled the mandatory criteria. He had polyneuropathy, he had a monoclonal plasma cell proliferative disorder. So we identified a M band and it was IgG lambda. And the other criteria that he met were, he had a sclerotic bony lesion, and he also had, he had skin changes and organomegaly. So he sort of fulfilled the diagnostic criteria for Poem syndrome. So we treated, because he had a single lesion, we treated him initially with radiotherapy. There was no response, and following that, we started him on chemotherapy. We gave him 4 cycles of the chemotherapy. With that, his symptoms improved. So the neuropathy improved. So initially he had severe symptoms. All those symptoms improved. So we repeated the M band. So the monitoring was done by, there are different ways of monitoring this. You can do the, monitor it using EMG NCV, or do a protein electrophoresis. Here we did the serum protein electrophoresis, and the M band sort of disappeared. There's no, the immunofixation and the serum protein electrophoresis essentially showing, disappearance of the abnormal protein which was there before. So essentially after the chemotherapy, the M band from 0.77, there was decrease in the gamma region, and the immunofixation from IgG lambda became negative. So as the standard treatment, he underwent autologous transplant, and even after 3 months, as we said, after 3 months post autologous transplant, we generally do assessment, and then in myeloma, maintenance therapy started. Poem syndrome, essentially there's no role for maintenance therapy. So we did an M band. There was no M band. Free light chain ratio was borderline deranged. It was 2.32. But because the M band was negative and he was asymptomatic, we just monitored him. And just to tell you how the disease responds, his weight when we did the transplant, just before the chemotherapy, was around 62. When he came for follow-up, it increased to 89 and 91. So, the general health, when we look at a lot of parameters for monitoring, weight is a very important clinical parameter that we use to monitor therapies. So this gentleman had his general well-being improved after the transplant, and currently he is doesn't have any symptoms. He's off all therapy, except for his thyroxine supplementation. And in Poem syndrome, many of these transplants are curative. So he's now about three years from the transplant so he's recently got married, and he came for follow-up. M-band was not there, and he's doing well otherwise. So any questions related to the second case, or we move on to the third one?
No
Sorry, sir. There are a couple of questions, but we can take it later because it will be related to.
Okay. So moving on to the third case. So again, Dr. Ishita.
Yes, sir. Case 3, 44 years old, chronic kidney disease on maintenance dialysis, systemic hypertension. Renal biopsy done in August 2016 shows cast nephropathy. Investigations done shows increase in beta 2 microglobulin and M band of 0.54 grams with increase in creatinine.
And so we
And
did
albumin
further
is also.
evaluation. Yeah.
Immunofixation shows IgA with 50% plasma cells on bone marrow aspiration, and there's an increase in the FLC ratio. And skeletal surface also shows multiple lytic lesions.
Yeah. So would you like to comment on the diagnosis here?
Um,
So yeah, so this is essentially, if the since the renal biopsy was done, which showed a cast nephropathy, even in absence of myeloma, this would merit treatment. But on the marrow, we got 50% plasma cells, so the ultimate diagnosis is IgA myeloma with chronic kidney disease. So we treated her with BTD chemotherapy 5 cycles, and because the M protein was small, we monitored the free light chain ratio. So this was less than 1 gram. So we use the free light chain ratio for monitoring these patients. So the free light chain ratio was 139 to begin with, and that reduced to 1.3. So in fact, it is the difference between the involved and the uninvolved light chains that is monitored, and that is showing a nice reduction with therapy. So post that, so we use the free light chain ratio for monitoring this disease, and we continued the hemodialysis. So she underwent autologous transplant while on, because she had chronic kidney disease, we had to continue the hemodialysis. But we subsequently did an autologous transplant on her, continuing the hemodialysis. And post transplant, somewhere around 100 days, we did repeat assessment with the free light chain ratio, and it was in the normal range, 1.3. We continued thalidomide maintenance for her. So currently she is continuing hemodialysis, erythropoietin and thalidomide, and currently, she's clinically well and on OPD follow-up. There is no M band. The immunofixation is also normal, and classically because of the chronic kidney disease, both kappa and lambda are elevated, though the ratio is normal. So this, generally with renal failure, we may have elevation of these light chains, but the ratio here is essentially normal. So that's I think the last slide. Yeah, this is our current serum protein electrophoresis graph. Yeah, that's all. Then. Thank you, and would be happy to take questions.
Thank you so much, sir. So there are a lot of questions from our audience. So we can start with, okay, so what is the difference?
Shall I take up the questions?
Yeah, Bonita, you can start.
So we have lots of questions, starting with how could we detect monoclonal on top of polyclonal band?
So how do we
detect monoclonal on top of polyclonal band?
Yeah. So a polyclonal band, as I've shown you on the slide, is broad and diffused. Okay, you can have a monoclonal component sitting there. So you can see that monoclonal sometimes, which may not be very clear, but in the electrophoregram, you will see you can see, instead of seeing a polyclonal hump like such, a broad one, you will be able to see some kind of, though the base is broad, probably you can see a little bit of a spike on top. That could be the band or a faint band or some kind of restriction there that is sitting there on top of the polyclonal band. How would you detect it? It is by immunofixation. You have to do immunofixation. So when you do immunofixation, it will show you very clearly what the polyclonal is, and it will show you if there is the real presence of the the monoclonal component sitting there.
Thank you, ma'am. How to diagnose non-secretory myeloma?
So non-secretory myelomas we would diagnose by doing bone marrow examination and doing light chain restriction on using immunohistochemistry. So it's not so once in a while we do see non-secretory myelomas, they would present with all the other features, hypercalcemia or anemia or renal dysfunction, but there is no detectable M protein in the blood. But evidence of clonality on immunohistochemistry with light chain restriction can be done, or either on the bone marrow or on a biopsy of the plasma cytome.
So what is the difference between Waldenstone macroglobulinemia and multiple myeloma of IgM isotype?
So, it's essentially the in Waldenstrom, it's B cell malignancy. So, it will be a CD20 positive neoplasm there, whereas myeloma cells would be CD138 positive. And I would request for comments from Dr. Sujay and others also.
Yeah, I think the context is different. They would present differently. And of course, like you rightly said, it's B cell neoplasm versus a plasma cell neoplasm. And I don't know, have we had difficulties in differentiating Waldenstrom's from myeloma, IgM myeloma? I don't know.
The question was IgM myeloma and Waldenstrom. So
yeah.
I think
Has there been any difficulty for Dr. Uday to differentiate Waldenstrom's clinically from Waldenstrom's and IgM myeloma?
Clinical presentation is quite different.
Yeah.
So, that's pretty evident on that. And I think based on what I understand is the CD138 and 20 being specific markers for each of those two entities can help differentiate the two.
Shall I come in? I'll just
Yes,
one
please.
additional thing from flow cytometry. What happens is the lymphocytes in Waldenstrom macroglobulinemia, they are clonal. So the lymphocytes will show a clonal population, while plasma cells are usually polyclonal in Waldenstrom. So LPL has the lymphocytes are clonal, while in myeloma you have clonal plasma cells and lymphocytes are polyclonal.
Thank you.
So
Thank
it's
you
a
so much.
lymphoma. Yeah.
Okay.
LPL is a lymphoma. So that's in flow we can easily distinguish between the two.
No, I think the question was referring to IgM myeloma.
Even though with that IgM myeloma, plasma cell would be clonal in the this thing, so flow cytometry in IgM myeloma. Yes, sir. Yes.
Thank you, Shweta ma'am. If another question, if there is M-band and immunofixation proves clonality, is there need for light chain restriction in bone marrow transplant if plasma cells are more than 10%?
Yeah, so basically the diagnostic criteria we have to document it's everywhere it's mentioned clonal plasma cells more than 10%. So routinely it would be necessary to do light chain restriction on immunohistochemistry and not just rely on plasma cells being more than 10%.
Another question, if MGUS is picked up on screening, what is the follow-up protocol?
So we generally classify these patients as some of these are low risk in terms of if it's just an IgG, MGUS, and the M protein is less than 1.5. So some of them we may not do a marrow also, and we would just follow them up every 3 months. Whereas there are certain groups of MGUS wherein we would do a marrow to ensure that there is no myeloma at that time point, and then follow them up every 3 months serially.
So how to differentiate urine protein electrophoresis and serum protein electrophoresis?
Urine protein electrophoresis is done on another gel, which is called the HR gel, agarose gel. Okay, and a serum protein is done on another agarose gel, or serum protein can be done on capillary electrophoresis. Now, when you do urine protein electrophoresis, when you run the urine samples, as I showed you on the agarose gel, you can see the various types of bands formed or not formed. Normal person will not have any bands. Persons with kidney disorder, nephrotic syndromes and all that will have a proteinuria. And a patient with light chain disease or a multiple myeloma will have a band which is very dense, which will be sitting anywhere between the alpha to beta and the gamma region. So it is, they're not mixed together. The samples of urine and serum are not mixed together. Urine is done on one gel and serum is done on another gel. That's it. That's the difference.
So another question is how Ben-Jones protein detection is done? By which method?
Benzoyl detection is done by the agarose gel method, where the stain that is used is the acid violet or the amido black stain, which can be used. The olden days screening method, which was the heat precipitation method or the sulfosalicylic acid method, that is very old, maybe about 30 years back, but that was a very, very vague screening method which would give you a precipitate. But the one which is very sensitive is the agarose gel method. So your BJP, which is a light chain, can be picked up only on that.
Another question is Waldenstrom or LPL is a precursor of MGUS?
I think it's reverse. You know, the I don't think the Waldenstrom.
Yeah,
The
it doesn't
question is
make
whether
sense.
Waldenstrom is a precursor of MGUS. No.
In a case of suspected multiple myeloma, plasma cell percentage less than 10% and all other clinical investigations suggest multiple myeloma, then what's the then what is multiple myeloma or MGUS? How reliable the marrow percentage in such cases?
Yeah, so generally what we would do is we would do some form of skeletal imaging, a PET CT, to detect whether there are plasmacytomas and try and biopsy that. You know, because if your bone marrow plasmacytosis is less than 10%, and you have multiple plasmacytomas, that also would, you know, fulfill the criteria and you would treat these patients. So, you know, we would do some form of skeletal imaging to detect for plasmacytomas in such patients.
Other question is what is QC of SFLC ratio estimation? QC.
There is no QC. I think the person is referring to quality control.
Yes, ma'am.
Yes. So there is SFLC ratio. It's a ratio. It's a number. But QC is done. QC is done for the kappa and for the lambda. So you have a QC for kappa lambda and then you run the samples. But there is no QC for the ratio as such. When the patient samples are run, after you run the quality control, you are confident that the patient samples for kappa and lambda, which gives you your ratio, is correct because you've already done the QC. So there's no QC for a ratio as such.
Another question, does plasma cell before fish means doing the fish in plasma cell mostly?
So the fish is done after plasma cell enrichment. So marrow is collected and then plasma cell enrichment is done magnetically. So magnetic separation followed by fish is what, and that's the recommendation, to do plasma cell sorting and then doing fish on that.
Have more questions? Should we take up, sir?
I think 2-3 more questions are there. Maybe we can finish.
Okay, ma'am. One question. Should all minor distortion in beta and gamma region with reverse AG ratio be by IFE?
Yes, from the lab point of view, whenever there's a minor distortion and we mark a query, whenever there is any minor distortion and we're not able to comment, because to comment on something that on a myeloma or commenting on a cancer on a query is not right. So it is usually marked as a query faint band or a query band, and then the clinician decides whether immunofixation is required at that time or maybe later. But minor distortions, it's important that immunofixation is run, because you probably can see a band, probably there would be a band, it would be a BMGUS or an early stage as such. Uday, if you can comment further on that.
The question was about the
that is, we mark as query.
Yeah.
We give you a result as a query band in beta, query band in gamma. These are the minor distortions.
So we would do a immunofixation at that time point.
Yes.
To see whether there is, and if there is a query, then we would also do a marrow to look at, as we had illustrated in the first case, whenever there are discrepancies, generally we would do a marrow to see whether what is the disease status there.
We have another question. Can IFE quantify various immunoglobulins?
IFE is a qualitative test. There is no quantification of IFE at all so far. But the quantification of that particular band is already done on serum electrophoresis. Okay, but if you want to quantify the light chains, for that particular patient, it is called the serum free light chains. That is done by the spectrophotometric by a kit, the binding site kit. So quantification of the light chain can be done if at all it is there. I mean, to know whether that's if there's a free light chain, but not on an IFE.
Another question: should we do serum immunofixation even in the absence of M-band in SPEP in patient with high suspicion? And also, should we do urine protein electrophoresis or immunofixation in all patients?
Serum immunofixation in the absence of M-band. Why would you want to do a serum immunofixation in the absence of M-band? Serum immunofixation is done to confirm what type of immunoglobulin is present, what type of myeloma, what type of immunoglobulin, IgG or K, because G and A is usually multiple myeloma, and you say M is the Waldenstrom's type, which present differently. So why would you want to do a serum immunofixation when there is no band? That is point one, so there is no need. And if there is the latter part of the question is with high suspicion. With high suspicion, you will have an electrophoresis done, which is negative, which is normal. Then the next part, the B part is, should we do urine protein electrophoresis and or immunofixation in all patients? No. You don't. Only when there is a suspicion, I think the doctor or the clinician would request for a urine protein electrophoresis, and immunofixation is requested for the ones who have a query band or a positive band. Is that okay, Uday?
Actually, sometimes, about 15 to 20% of patients with light chain myeloma may, we sometimes detect only on the basis of free light chain ratio derangements. And I'm not too sure. I think in some of them, even the immunofixation might show light chains, not the heavy chain may be absent in them. So the complete protein may be absent. So the M-band may be negative, but the immunofixation may show, say, only lambda or only kappa, and the free light chain ratio might be deranged. So there are few patients that we see in that space.
Yeah, we have observed cases of hypogammaglobulinemia. When there is a high suspicion of myeloma, we proceed with immunofixation and we pick up light chains on, but most of these cases have a flat gamma region. They are hypogammaglobulinemia cases. We have not come across normal gamma globulin peak, a broad peak, and then IFE showing a light chain. But hypogammaglobulinemia, yes, we should certainly go ahead and do an immunofixation.
And the light chains can be picked up by the serum free light chain test.
We have few more questions. Biologically, how to differentiate normal plasma cell versus reactive and versus clonal plasma cells? Any specific criteria for morphological detection?
Request someone else to take that question, either Dr. Sujay or Dr. Shweta.
Rajiv sir, also if he can pitch in
Yes,
here.
sir.
Yeah, I wanted to add something to the previous question on the need for immunofixation if there is no M-band on the serum. Was that your question, Bonita? The previous question?
Yes, sir. If there is no
If there is
M-band,
no
do we need to
M-band
do
in
immunofixation
the serum,
if there is a high
then
suspicion?
yes. The answer, as Dr. Uday also was saying, and so the answer is yes. In this situation happens generally when you're dealing with a light chain myeloma. The light chains are very small, so they get filtered and they pass into the urine, but still there may be some amount of light chains in the serum also, which you can pick up on the serum electrophoresis, even if there is no M-band. That is one. And in all these cases, you will find an M-band, a light chain in the urine. And secondly, as many of the faculty members must have seen, IgD and IgE myelomas will generally be picked up on immunofixation, not on electrophoresis, because they don't give a very sharp impact. And Bonita, one more thing for you. Immunofixation is done to identify the kind of chain that you have, the heavy chain or the light chain, whether it is alpha, beta, gamma, and all that, or and lambda and lambda and kappa, not to quantify. Is that clear?
So on morphology, is there any way we can distinguish between normal versus reactive plasma cells, or say that they are clonal or suspicious on morphology?
If the plasma cells are very abnormal, you can certainly suspect, and I mean, one should indicate. Very abnormal plasma cells generally will not be seen in reactive conditions. It all depends on which classification of morphology you're following. I do not know about WHO, but in the ECOG group, when you say plastic plasma cells, they look like ordinary blasts. They don't look like plasma blasts. So I do not know about the WHO.
So even the presence of lame cells and all is indicative of some clonal.
Not necessarily.
Okay. I think there is one more last question. How to quantify IgG and IgA? What's nephelometry?
It is done by turbidometry.
Turbidometry.
Quantification of IgG and A is done by turbidometry method. It's a kit. You can quantify that by turbidometry, yes.
I think we are done with all the questions. Bonita, is there anything else you see?
Yes, ma'am. Is CD56 expression is a good or bad prognosis for multiple myeloma?
Don't really look at that. It's not a very important, well accepted prognostic marker in myeloma, is what I understand. We don't use it for risk stratification or for
It's just an aberrance. It's sign of an aberrant plasma cells, but not really for a prognostication.
One more question. Should clonality confirmation be done in all cases, even if myeloma cells are more than 10% in marrow? FLC, what if FLC is not distinctly kappa or lambda?
No, we as I understand that the current diagnostic criteria requires documentation of clonality by doing light chain restriction on either the bone marrow biopsy or the plasma cytoma biopsy, whichever, but the clonality has to be established by, you have to show light chain restriction.
That's all.
One more thing for Bonita. Bonita, you were asking about urine electrophoresis and serum electrophoresis.
Yes,
urine has a smaller concentration of protein generally compared to serum. Therefore, when you do electrophoresis of urine, then you should concentrate the sample of urine first. My understanding is that in most labs they use an Amicon concentrator. Is that right? So there is something known as a concentrator made by by a company which people import. But if you do not have that, you can concentrate the urine also by doing dialysis using table sugar, just table sugar. So it's very cheap. Take a dialysis tube, put the urine about 30 ml, put it in sugar, table sugar, leave it in the fridge for a few hours or maybe overnight. When you come back the next morning, that 30 ml would have become about 1 ml. And then you take it out and do the test. So you don't have to import this material.
Thank you, sir.
And just one last comment about the nephelometry. I think what I the paper that had circulated with all that also has the comment on the nephelometry and what are the advantages and disadvantages of using both. So what in general, I think nephelometry seems to be more accurate in quantification in certain situations, especially when in IgA myelomas where the band may be there in the beta region. I think that's what the question was alluding to, I suppose.
I think we are done with most of our questions. If there is any concluding remarks from the speakers
and the chairpersons.
I would like to add one thing. Bands on serum electrophoresis. We call them alpha 1, alpha 2, beta. So can anyone answer why those terms are used? Alpha 1, alpha 2, beta 1, beta 2, whatever, and gamma.
Students, Dr. Rishita.
What do those terms indicate? Alpha 1, alpha 2, beta, gamma. Indicate only the speed of migration. They indicate only the speed of migration. The fastest migrating is albumin. Behind that is alpha 1, then alpha 2. Then there are 2 bands in beta, and then finally gamma. There is actually no protein known as alpha 1 protein or alpha 2 protein. They just indicate positions. The most important protein at the alpha 1 position is antitrypsin. You must have heard of that. And in alpha 2 position is
alpha 2 macroglobulin
or alpha 2 macroglobulin. And in the beta region, you have got transferrin and complement. So those are the named proteins. And in the gamma region, of course, you have the immunoglobulins. But the immunoglobulins can be seen anywhere from the gamma region to the alpha region. Don't think that it will be present only in the. Is that clear?
Yes,
All the
sir.
students?
Yes, sir.
Yes, sir.
Any concluding remarks from any chairperson?
Yeah, I think it was a good session, and what is important is to understand that the protein electrophoresis produces a pattern that we need to see in conjunction with the context. It should not be interpreted in isolation, like any test in biochemistry or hematology or histopathology. The context makes a lot of difference. So please don't hesitate if you see an abnormal gamma protein to consult and understand the clinical picture. And if there's a suspicion, do not hesitate to ask for immunofixation. I think that's the key point that I would want to share.
Okay, so I guess with this, I would like to thank our speakers and chairpersons and the students. Thank you, speakers.